123454321. Good morning for those of you just entering. It's Seth Stander from the Hope and Healing Center and Institute. We're going to begin in about 1 minute, but we wanted to get you settled in. We have a meaty final selection to go through this morning, our last session of Aging with Grace for the spring of 2023, and we'll begin in just another minute or so. All right, we are at the 10 o'clock hour. A formal welcome to those of you who are joining us live or who are watching this at your convenience. We're glad that you signed up to participate in our Aging with Grace series. I am Seth Stander, the Community Aging Specialist for HHCI CARES, which is a part of the Hope and Healing Center and Institute. For those who may not yet be familiar, our acronym CARES stands for Caregiving, Aging, Resilience, Ethics, and Spirituality. This is our fourth and final Aging with Grace session for the spring, and today we will be focusing on paying for aging. Now, each session has been recorded, and said recordings and slides will be made available to you following our series. Each of these sessions are part of CARES' mission to serve our growing aging population and the growing population of caregivers who attend to them. In addition to community education, CARES offers consulting with special emphases on the hopes and challenges of aging, on bioethics, on the hopes and challenges of caregiving, and on navigating the journey of grief. HHCI CARES is directed by Dr. Peggy Dettermeyer, who I am pleased to serve with, and we are here at the Hope and Healing Center and Institute on the campus of St. Martin's Episcopal Church in Houston. HHCI is dedicated to meeting the psychosocial and emotional needs of the entire community, and thanks to very generous underwriting, we are grateful to offer our programming at no charge to participants. So, I believe everyone should have my slide deck cover page on their screen. And let's go ahead and dive right in. Like I said, lots of stuff to go ahead and expose you to this morning. First and foremost, a disclaimer that this is an overview of available options when it comes to paying for aging. And we're talking about not just daily routines that one has when they happen to be older, but also when we're talking about paying for aging, we're talking about perhaps acute care needs, post-acute care needs, living needs, assistance with activities of daily living, and more. So it's important not just to get a good handle with the appropriate clinical professionals on your specific circumstances. It's also best to consult financial planning professionals and get more concrete information that applies specifically to your situation, depending on where you find yourself in this stage of life. So we're going to cover 4 general areas. The costs associated with aging, as I alluded to just a few moments ago, how Medicare and Medicaid are employed in this task of paying for aging, what private financial options may already exist or maybe ones for you to consider, and we want to make sure that, like every slide deck, you receive a full set of resources that we have based our information sharing on this morning. So let's talk in general about the cost of aging. Most people are going to age into the point where they will be paying Medicare premiums, Medicare deductibles and copays, and various drug copays. An organization called HealthView Services, which is linked at the end of the slide deck. And these numbers are going to change over time, but as a snapshot in time, the link that you can click on indicates that a 65-year-old couple can expect to pay around $400,000 for the various costs of aging over 20 years. That does not, I'm sorry to say, include the cost of various care facilities, whether those are acute care facilities, post-acute care facilities, or long-term care facilities, all of which we have covered in our previous parts of the series. And I certainly encourage you, if you have registered for those previous seminars in our Aging with Grace series, to go ahead and review the recording and slide decks of those when they arrive in your inbox. Or you can simply go to the resources part of our website at hhci.org, and you'll be able to go ahead and view the recordings, which will, of course, include the slide decks as they were presented on each day. So let's talk about some average monthly care costs. For a homemaker or for a home health aide, we are talking about a wide range, because as we talked in earlier seminars on Aging with Grace, on the skill set that is needed for someone who is a home aide, non-clinical, versus a home health aide, clinical, we could be looking out of pocket if it is not, especially on the home health care side, prescribed and therefore covered in part or in whole by Medicare, anywhere from $4,000 to $8,000 a month for someone who is aging in place in their home. If one has also opted for some type of adult daycare experience, and primarily this is for folks who are experiencing some type of physical, but also some type of perhaps cognitive decline. We've talked in previous sessions about the adult daycare centers that exist here in Harris County, such as those operated by The Amazing Place, operated by Care Partners. And the average cost per day, when you go ahead and spread it out, you can be looking at an average of around $1,600 per month for that service. This again presumes that you or your loved one is returning to a home environment after that daycare experience. For an assisted living facility, and we talked about how wildly divergent the range can be based on the amenities, the location, the upfront costs, let alone the monthly and a la carte costs. But if we were to assign a general average to a type A or type B licensed assisted living facility in the state of Texas, and in specifically Harris and surrounding counties, you would be looking at an average of $3,750 a month and up. And when I say and up, I have to say that it can be significantly higher depending on the location, whether it is part of what is called a CCRC, a continuous care retirement community, in which assisted living is a component along with independent living, and so forth. When we talk about personal care home experiences, we made a differentiation in our previous settings on what is licensed, that is to say, 4 or more beds, versus what does not have to be licensed in Texas, 3 or less beds, as a personal care home model. The model may look very similar in terms of taking a residential property and converting it for use as a personal care facility, a personal care home, a PCH for short. But the rules of licensing, and more importantly, when it reaches that 4 or more bed capacity and becomes a licensed assisted living facility that follows a personal care home aesthetic model, you as a resident or your loved one as a resident will enjoy more robust protections than the mere landlord-tenant arrangement that would very likely be the case. Your only protection, primarily your own, I should say, when it comes to the 3-bed or less model of a personal care home. Now, the price is going to be less in a personal care home that is unlicensed, and you very well may find a good match in terms of the operator, their clinical as well as administrative skills, nutritional skills, and more. But again, we recommend licensed facilities wherever possible because they are subject to oversight and regulation by Texas Health and Human Services Commission, their long-term care regulatory arm. And you have resident advocates available to you in the form of long-term care ombudsman. Now, this is certainly going to be the case if you look at a nursing facility let alone a nursing facility in which a secure memory care unit exists, and a nursing facility in which you have a skilled unit for short-term stays, such as skilled rehabilitation, or perhaps wound care or IV antibiotic therapy, which we've mentioned in previous sessions. But ultimately, it is going to be the most expensive option, the average. And again, this number goes up depending on where you are and what other aesthetics and amenities are included. The average in our and around our county is $7,200 a month and above. So we're talking about a significant monthly outlay, regardless of where you choose and where is ultimately safest for you to reside. With that in mind, let's talk about what Medicare and Medicaid can and cannot do in order to offset the financial cost of whatever setting is most appropriate for you. And in order to do that, we need to go ahead and we need to talk a little bit about the general understanding that I hope most people already have, and if you don't, that you gain today by understanding the roles that Medicare and Medicaid play in your lives when the need arises and when you qualify for said services. First and foremost, Medicare is a federally funded program. It's primarily for those who age into the program, 65 and above. But there are provisions for gaining Medicare benefits based on disability. Whereas Medicaid's funding is primarily state-based, with some support from the federal government if your state has opted in to Post-Affordable Care Act Medicaid expansion. Now, I must tell you that Texas has currently chosen to opt out, and I don't see a change in that in the foreseeable future. But depending on where you are, if you are outside of Texas watching us live or watching this recording, you may very well see an expanded Medicaid funding because your state has opted in to post-ACA Medicaid expansion. Something to keep in mind in terms of the funding sources. As we all know, the greater the pool of money, the more likely that you are able to go ahead and make the most use of it. So what does it take to go ahead and to be qualified for Medicare? Well, ultimately, the person who is applying for Medicare based on age or disability or their spouse needs to have paid into the Medicare system for 10 years or more. So ultimately, you will need to go ahead and to look back and ensure that either you or your significant other have met this minimum qualification as far as accessing Medicare benefits. Otherwise, if there are exceptions to the rule, you will certainly want to talk to area agencies on aging, whether in our county or your local county, if it is not Harris County, to discuss what exceptions to that rule may apply, particularly when it comes to disability. Medicaid ultimately is for those people with severely limited income and financial resources. And those maximums in terms of what you can make your applied income, in other words, each month, and what you can save, what is primarily in a liquid savings account, is going to differ by each state. And we'll talk about the numbers here in Texas in just a few slides. So let's make sure we all understand when it comes to Medicare what the different parts stand for. It's not intuitive, I'm sorry to say, and so I'm hoping that we can go ahead and deconstruct this a little bit, break it down into its component parts in a way that you feel confident understanding, and if need be, describing to others, perhaps in your own circle of family, for example. So Part A of Medicare is your general hospitalization. There is no premium attached to Part A Medicare, but there are deductibles that come into play based on the duration of your hospital stay. We'll get into some more of those details, but let's continue on with the general descriptions, and we'll break them down in future slides. Part B is known as your major medical component of Medicare coverage. There is a sliding scale premium for this, and ultimately we're talking about outside of acute care settings. What is needed in terms of perhaps durable medical equipment, some elements of perhaps home health and hospice care may be covered under Part B of your, in other words, your major medical, and we'll get into those as we go further. Now, I'm going to skip Part C for a moment and go to Part D, and just remind everybody that Part D is your prescription medication part of Medicare coverage. And your premium is going to depend on the plan that you have. And ultimately, we'll talk a little bit about what your contribution is now in terms of your participation in paying copays and other such deductibles. And what is coming in the future. Help is on the way for those who are not quite into Medicare yet, or who may be receiving Medicare as a benefit, but may be paying a little bit more than they expected when it comes to prescription coverage. Let's go back a step and talk about Part C. Part C is what is known as the Medicare Advantage Plan. Now, ultimately, Part C takes the place of Parts A, B, and D under traditional Medicare, folds them all together into a comprehensive plan. It is a competitive market. There are literally dozens of different Medicare Advantage plans that are out there, Part C plans, and the premium depends on the plan being offered. So we're going to advise you to be a savvy shopper, and of course, to direct your attention not just to individual Part C Medicare Advantage providers, but to get the best advice possible, not only from your area agency on aging, but also your Aging and Disability Resource Center. Here in Harris County, that is Care Connection. It may be known by simply the ADRC or acronym or another name in surrounding counties or in your area if you are outside of Texas. Part A Medicare. So as I mentioned before, your hospital stay is, of course, the primary purpose for this coverage. But beyond that, we want to go ahead and make sure that we give credit where it's due to what Part A Medicare covers post-acute stay, which is to say, if you look at below the box where it says acute care hospital stay, you may be able to qualify for inpatient rehabilitation therapy in an IRF, in an inpatient rehabilitation facility, depending on what put you in the hospital in the first place, and whether your recovery is primarily focused on various types of rehabilitation, whether we're talking about physical rehabilitation, occupational rehabilitations, speech rehabilitation, and so forth. Now, the qualification is also based on your ability to withstand 3 or more hours a day of said therapy. So long as that is attested to by the prescribing authority and demonstrated by you as a compliant inpatient rehabilitation facility resident, you're fine. If you are not meeting those standards after being deemed qualified to meet those standards, if for some reason there is an issue of noncompliance, you can expect what is called a notice of Medicare non-coverage coming to you at some point pretty soon after it's determined that you may not, in fact, be able to withstand 3 hours or more of various therapies throughout the day. Now, another post-hospital component of this is what's known as the LTAC, the long-term acute care hospital. And this is where ultimately you'll go. You have up to a 60-day lifetime benefit. Ideally, you're going to need far less time than that to go ahead and to be handled properly by clinical professionals when it comes to making sure that IV antibiotic therapy and wound care are properly administered. All of the components of an LTAC and an IRF may be considered part of the skilled component of a nursing facility where you may be discharged to after your hospital stay. Remember, you have some choices based on what is prescribed and what your prescribing authority attests to in terms of what you can withstand. We've talked in previous sessions about how a nursing facility may have an excellent skilled staff, whether they're focused on rehabilitation, whether they're focused on antibiotic or wound care, or anything else related to the skilled side of what brings you to that nursing facility. However, based on the staffing levels and prioritization of getting you up, getting you cleaned, getting you fed, getting you dressed, and therefore ready to engage in your various therapies, you may end up being frustrated. So it's important to get the best picture possible if you are looking at nursing facilities with the hospital case management team as they consider discharge planning for you, to make sure you talk to a long-term care ombudsman who can tell you what the staffing ratios are at that nursing facility, and based on their direct observation, how likely it is that you are going to consistently be made ready to go ahead and to engage in the therapies that bring you to that facility in the first place. Another piece related to Part A Medicare, and again, some of this is going to be considered in Part B Medicare as well. Let's talk about the part that ultimately is part of that, depending on circumstances, can be both Part A and Part B. And here we're primarily talking about the home health component. To a certain extent, the hospice component may apply, although they are both primarily components of Part A Medicare coverage. So let's talk about hospice as a subsection of palliative care. Both are covered by Part A, but palliative care is an umbrella category that talks primarily about comfort care, or if you prefer the term, symptom management. And the goal here ultimately is to go ahead, whether someone is diagnosed with a life-limiting or terminal disease, or not, depending on their condition, symptom management, if it is a chronic condition that may or may not be life-limiting, that may or may not be terminal, palliative care, comfort care, symptom management may absolutely be an important component of the overall care that you receive. Now, if you have been diagnosed with a terminal illness for which the prognosis is 6 months or less, then we move into the subsection of palliative care known as hospice. As we have discussed previously, hospice is primarily a residential-based service. There are circumstances, and they are very specific circumstances, under which inpatient units will take you as a hospice patient. Primarily, most people enrolled in hospice are going to be in a residential setting, whether that is your own home, whether that is independent living, assisted living, or a nursing facility. It is important to note that while a robust interdisciplinary team that consists of a medical director, a resident nurse case manager, a medical social worker, a chaplain, and the backbone of all of this, the hospice nurse aides, are all terrifically prepared to take the best possible care they can of you or your loved one while they are enrolled in hospice. They are not there 24/7, and only certain components of them are available for consultation on demand. So make sure you discuss with multiple hospices. We don't make recommendations, by the way, outside of the nonprofit or not-for-profit sector. Right now, that essentially means Houston Hospice in Harris County. And we are seeing a transition in hospice care, a partnership that appears to be created, in the process of being created, or has just completed its creation, between Memorial Hermann and outside hospice, where they used to have inside hospice services under the Memorial Hermann umbrella. We're not certain whether that truly counts as not-for-profit at this stage, so we'll name them cautiously for now. When it comes to for-profit hospices, our area has literally dozens of hospices that operate in and around Harris County, let alone throughout the state of Texas. It's important for you to interview carefully, and by all means, you can consult with us. You can consult with the Area Agency on Aging, with the Aging and Disability Resource Center about what questions you want to ask when it's time to shop for hospice providers who will meet your or your loved one's needs. The same thing applies to a certain extent when it comes to home health care. As I've described previously, home health care is prescribed service, which will include therapy, physical, occupational are the primary ones that are used, and it is a residential / homebound service, which is to say you are not able, medically, it's determined that you're not able to go to outpatient therapy, and therefore that therapy needs to come to you. A similar kind of interdisciplinary team exists in home health care. Depending on where it has been prescribed, it is going to be covered either by Part A or by Part B of Medicare. Now, it's important to note that what is called the 3 midnight rule is certainly, especially as we move past the public health emergency, now very much in force and will remain in force for the foreseeable future, which is to say, You need to have stayed in a hospital for 3 consecutive midnights in order to qualify for a nursing facility stay, which is to say, to utilize the skilled services that that nursing facility provides. Should you be prescribed skilled services, the various therapies we've mentioned previously after discharge from a hospital. If your 3 consecutive midnights include ICU stays, that's when you will qualify for the LTAC setting. So it is sometimes not a choice between LTACs and the skilled side of nursing facilities. But if you have gone through a serious enough acute incident to put you in the ICU for 3 consecutive midnights, that choice is absolutely there. And I encourage you, wherever possible, to opt for the LTAC setting in order to continue your recovery post-hospital discharge. If you are an observation patient or an admit patient in a hospital, these aren't going to work if you're observation only. You have to have been completely, fully admitted, and your status is inpatient status. Now, that doesn't apply to IRFs, to inpatient rehab facilities. It does apply to nursing facilities, does apply to LTACs with the provisos I've mentioned. But inpatient rehab facilities, whether you're an observation or an inpatient in a hospital, you have access to those, which is why I encourage you to make full use of them, as opposed to the rehab, the skilled rehab services that are available at a nursing facility if you have the choice. It is about staffing, but it is also about prioritizing in an inpatient rehab facility of every patient getting up, getting dressed, getting fed, cleaned, ready to go, because everyone there is there for rehab services. You have a 30-day window to admit to either an IRF or the skilled side of a nursing facility after an acute care, in other words, hospital discharge, and to restart the clock for Medicare Part A eligibility for all of the above. There needs to have been 60 days that have passed between the acute care incident that brought you to the hospital and another acute care incident. That's when those benefits reset at day 1. Now, ultimately, I thought it would be a good idea for you to have an idea of what your coinsurance expectations are as of federal year 2023. So for an inpatient hospital deductible, you're looking at $1,600 per visit. Daily coinsurance for days 61 through 90 of a hospital visit, that's going to go ahead and that's going to add another $400 a day to your bill. Your lifetime reserve, which is up to 60 days after you finish that day 61 through 90 daily coinsurance, in other words, day 91 and above, is going to bump up to $800 a day. And when it comes to the skilled side of the nursing facility, you're going to have a coinsurance of $200 a day. All of this is not to scare you, but rather to prepare you should an acute care incident exist. You need to understand what your out-of-pocket costs may be, which brings us all the way back to the first session of Aging with Grace, when we talked about healthcare rights and responsibilities. And one of the rights that you have is bill transparency. And one of the responsibilities, I would argue, that you have is to negotiate with the hospital when it comes to any out-of-pocket costs. We talked in the first session of this series about whether or not you are the recipient of amazing private insurance, of traditional or Medicare Advantage insurance, or whether you are self-pay from day one in a hospital, transparency in billing, negotiate when it comes to the out-of-pocket costs, whether they represent a part or the totality of your stay, because the hospital would rather receive partial payment than no payment. Let's move into Part B. Our major medical component of Medicare. And you can see ultimately there's a whole host of services that are here: medically necessary services and supplies, preventative services, your lab work, outpatient visits, diagnostics, in other words, various scans, selected special outpatient medications, those injectables or infusions that you can do on an outpatient basis, and the DME, durable medical equipment, for which there is typically a 5-year replacement allowance. This is going to include such things as bedside commodes for your needs, your bodily needs, excuse me. It is not going to include shower chairs, although thank goodness those are not terribly expensive for most people. Ambulatory equipment conflicts. What does that mean? It means that you can ask for either a walker or a wheelchair, and ultimately, if you graduate from the wheelchair to the walker, that's wonderful. Ultimately, being able to swap them out is something you should be able to do. And if there is an issue with that, then you need to go ahead and to make sure that you are, again, consulting with your AAA, your Area Agency on Aging, and or your Aging and Disability Resource Center, to make sure that the DME provider, the durable medical equipment provider, is following the rules. And the rules generally state you can't have both simultaneously covered through Part B Medicare. Anything on a list of DME can always be paid for completely out of pocket, but of course the goal here is to maximize your benefits. Now, I mentioned earlier, and I just want to point out again, that your home health, depending on the circumstance, could be covered by Part B Medicare. In other words, when it's prescribed by your physician, but it's unrelated to an acute event that required hospitalization. So it's possible that you took a fall, you went to an urgent care, and you were discharged from the urgent care to home. You didn't require hospitalization, but you may require home health care in the form of some short-term therapy, in which case Part B rather than Part A should be picking up the tab for that particular benefit. When we talk about Medicare covered home health services, we're talking primarily about anything that is under intermittent nursing care with RN supervision being the ideal. We've talked about physical, speech, and occupational therapy in passing, and we've talked a little bit about the interdisciplinary teams, I should say, when we talked about hospice and home health very often having parallels in their IDTs, their interdisciplinary teams. That's going to include, again, backbone of home health, your home health aide. It's going to include whatever nursing services are coming to your home. It's also going to include social services, and it's going to include supplies. And as I mentioned before, you need to be qualified as homebound. If you can get to an outpatient therapy appointment on a regular basis, odds are home health is going to stop covering you. Now, they will continue to cover you as long as you need them, even though you may find from time to time that companies may claim otherwise. This is where you're going to want your physician and your area agency on aging involved if that scenario ever crosses your path, because Medicare states that there is no limit to how long homebound services with the interdisciplinary team, the supplies, the durable medical equipment being covered can be claimed so long as you meet the medically qualifying criteria. Now, there are limits in terms of how much of those services can be covered by Medicare. And as you can see on the bottom point of this slide, we're talking about anywhere between 28 to 35 hours a week when we talk about combining home health care aides and nursing services at your home. And that's something you'll want to go ahead and consult with the home health service. And if you need additional assistance from the Area Agency on Aging, they're a great resource for that too. Let's talk about the Part B premium. Ultimately, it is based on your modified adjusted income, and your annual gross income, I should say, is what AGI stands for. Your modified annual gross income, as you can see, it's basically a doubling formula based on whether you're filing taxes individually or whether you're filing taxes monthly, and your total monthly premium for Part B Medicare coverage is going to rise accordingly. There is a category beyond this, which I thought about squeezing onto the slide, of beyond 500,000 modified annual gross income versus, say, 750,000 a month for joint. But I figured that if you are in that category, congratulations, and you're not really going to be too concerned about what your monthly premium is. You should know what it is, but you can consult that on Medicare's own website. I figured for the majority population, 90+% of Americans are going to fall into the category of anywhere from less than or equal to $97,000 individually to 500,000 individually, less than or equal to 194,000 jointly, or 750,000 jointly. A brief word about Medicare Part C. As I mentioned, this ultimately replaces Parts A, B, and D, the Medicare Advantage plan. Some of these plans include dental, include vision, include hearing aids. Some of these plans have the flexibility to offer in-home supports and modifications should you find yourself aging in place and struggling to meet your activities of daily living without said modifications and supports being put in. It's important to be a savvy shopper, which is why you need to be aware that there are more than 60 plans, 60+ plans, just in Harris County, with different ranges of premiums and deductibles and maximum costs. Lisa Falkenberg, a reporter with the Houston Chronicle, did a series of stories a short time ago when it comes to the pros and cons of a Medicare Advantage plan. And you'll see, I put in italics, her focus wasn't just on the benefits that I just mentioned in the other points, but also on the limits of covered doctors and hospitals. It's important to have a clear understanding of whether your current doctor or your preferred hospital is going to be considered acceptable by the Medicare Advantage plan that you may be shopping for, because it includes additional supplemental plans for dental and vision and hearing, because it has the potential flexibility of offering in-home supports and modifications. Be a savvy shopper. Research, research, research. Medicare Part D. Anyone currently in Medicare probably is well aware of the coverage gap, commonly known as the donut hole, and how in 2020, it was declared that the donut hole, this coverage gap, was closed. I'm not sure I would have used the word closed. What it really means is currently, when you enter this coverage gap based on how much you have spent on prescription drugs for the current fiscal year, you are typically only responsible at that point, rather than a copay, for 25% of the out-of-pocket cost of said drugs. Now, the out-of-pocket cost may very well be a negotiated cost between Medicare and the generic or the specific brand supplier of the medication. And once you go ahead and pay a certain amount out of that, then you're back to co-payments. This is an arrangement that can be an exercise, I know, of frustration, excess work to go ahead and to figure out how close you are to the donut hole, whether you're in the donut hole, how much it's going to cost you to get back out of the donut hole and back to your standard copay. The good news is that starting in 2025, retirees' annual drug copayments are going to be capped at $2,000. This is going to effectively end the concept of the coverage gap, of the donut hole. The reason for this is that this was a provision of the Inflation Reduction Act of 2022, which President Biden signed into law. And this particular 2025 date is part of the many provisions that revise Medicare benefits as part of the details of the Inflation Reduction Act. So hang in there. Change is coming, and it should be for the better for most people on Medicare utilizing Part D for prescription coverage. Now, we're going to make a switch over into Medicaid. And when we talk about Medicaid, we're talking about a health coverage program primarily for low-income adults, for children, for the elderly among us, older Americans who have reached that rarefied air of elder status, and for those who are differently or disabled. As I mentioned, this is administered by states. There are federal guidelines, of course, for Medicaid, but the funding, depending on whether your state opts in or opts out, is either state only or collaboration between the states and federal government. There are a couple different types of Medicaid to keep in mind that exist. Traditional Medicaid is a limited coverage that primarily supplements home health needs, durable medical equipment needs, infusion care needs, and hospice needs. These are primarily covered by Medicare, but if there needs to be supplemental coverage, this is where ultimately Medicaid will also kick in based on your financial eligibility. There is what is known as HMO Medicaid, and ultimately all DME are going to be covered so long as there is pre-authorization. Home health, nursing facilities, LTACs, rehabilitation facilities, these are, again, with pre-authorization. This is where ultimately you're going to find additional help if you financially qualify to go ahead and to cover, especially when there are out-of-pocket costs associated with your stays in nursing facilities, LTACs, and rehab. There should not be necessarily much to go ahead and supplement when it comes to home health coverage. But again, Medicaid is there if you financially qualify to go ahead and to help with out-of-pocket costs related to those prescribed services. Now, a couple of long-term care concerns when it comes to Medicaid here in Texas. First and foremost, I mentioned earlier that there are applied income limits and there are financial asset limits when it comes to financial eligibility for Medicaid in Texas. In 2023, you can see in the first box in this slide that the individual and married income caps The number 2742 per month is an important number. It will change occasionally year to year, increase slightly, but we're not talking about major increases. And that is your monthly applied income. In terms of whatever financial assets you may have at the end of any given month. And here we're talking about liquid assets, savings accounts, checking accounts. We're not talking about the house you own, the car you drive, the possessions inside your home. We're strictly talking about liquid assets, but they can't be above $2,000 a month. Otherwise, your Medicaid coverage will be jeopardized. So that's why we're talking about very limited financial ability as part of the qualification for Medicaid. There is the concept, and it's a very important concept, of spousal impoverishment when it comes to going ahead and preserving some of your savings to make sure that the spouse who is not applying for Medicaid is not left destitute and homeless. And so ultimately, you have currently $148,620 as the liquid asset limit that the non-applicant, in other words, the spouse not applying for Medicaid benefits, can hold on to and still allow for financial eligibility for the spouse who is applying for Medicaid benefits. So it's going to involve a serious spend down of assets if you are looking to achieve financial eligibility for Medicaid. But if you are not blessed with significant financial assets, Medicaid is there as a safety net. Problems. The reimbursement rates in Texas could be a lot better, which makes doctors less likely to accept Medicaid. So that is something to keep in mind, whether or not your current physician, a primary care specialty, what have you, is going to continue to keep you as a patient if Medicaid becomes a primary payer source. A 5-year look-back period in terms of financial qualification. In other words, no quick revocable or irrevocable trusts being set up for the benefit of your family. There are certain irrevocable trusts that are going to be excluded from your eligibility consideration for Medicaid. If you have gone ahead and set up an irrevocable funeral trust or funeral plan, and as I mentioned, your house, your car, your goods in your home, all of that's going to be excluded from Medicaid eligibility consideration. However, after an individual has died, a number of states, not all of them, but a number of states participate actively in what is called MERP, the Medicaid Estate Recovery Program, which is to say what they have paid out, they're going to put a lien on your property to go ahead and to attempt to recover. Talk to an attorney about the exceptions to this rule in states where MERP applies. And yes, Texas is one of those states, but no, it should not by any means dissuade you from applying for Medicaid. Just make sure, whether you are talking to your own personal attorney, whether you are talking to an attorney from a service such as the Texas Legal Services Center or Lone Star Legal Aid, or wherever your legal aid program is in your county or state, you need to make sure to understand what the exceptions to the rule may be as far as how and if Medicaid estate recovery programs are going to be activated in your particular family situation. But I want you to be aware, for full transparency, when you are in a state where MERP is utilized, and again, Texas is one of those states. The long-term care criteria for Medicaid services. Well, that's where ultimately you need nurse supervision, where your needs uh, by an untrained caregiver are not going to be met, because you have wound care needs. You have a PEG tube, a feeding tube. You are living with a moderate to severe level of dementia. You have ongoing, sometimes flaring psychiatric needs, and the list goes on. You have a physician's order. In other words, that physician has deemed you medically eligible to enter a long-term care facility. And ultimately, you have the types of deficits beyond the physical, cognitive, visual, and so forth, that point to your physician, ultimately, that you cannot take proper care of yourself, that ultimately untrained caregivers are not going to be enough to care for you. A level of clinical supervision is required. These all flow together, in other words, in order to go ahead and medically qualify you for long-term care placement. And just to remind you, long-term care placement using a Medicaid benefit, again, assuming both financial as well as medical eligibility, is going to be at the nursing facility level. There are currently zero long-term care facilities in the assisted living category that accept Medicaid for payment. So we are talking about nursing facilities, and we are usually talking about, in those facilities, unless their census is unusually low, shared room experience. So keep all that in mind as you consider logistically what is going to be best for quality of life and safety. I can see that we are beginning to run short on time, so I want to make sure to get through some of the last few slides. And here I want to go ahead and introduce the broad-based category of what financial options exist beyond what we have already shared. Some of these are going to be pretty intuitive in terms of your savings, but I want to focus in on a couple of different items when it comes to long-term care, short-term care insurance, and I want to talk a little bit about reverse mortgages, the other categories, hybrid life and long-term care, and annuities. I'm going to gloss over for our purposes. They're not necessarily common options that are used, although if you are fortunate to be taking in annuities, God bless. It's a wonderful benefit to have, whether it's the result of your own personal investment, a benefit from your career path, or whatnot. Briefly, long-term care insurance plans vary massively in terms of their terms. You can pay for programs long-term care insurance provides with regards to in-home care, with regards to care facilities, or you can pay for programs that involve both. On average, a person will make use of a long-term care insurance plan for a little less than 2 years, but you're going to be paying an annual premium on average and upwards of $2,800 a year for what will ultimately be on average a daily allowance, which would be paid towards, again, whether it's in-home or facility care, $161 a day. For an additional cost, you can make that benefit average inflation adjusted. The medical qualification for this is, again, where due to physical impairment, cognitive impairment, you need assistance with at least 2 activities of daily living, 2 ADLs. I've mentioned this in previous slides, but I wanted to repeat it here because it bears repeating. There are official categories for what clinically constitutes ADLs. I've embedded them in these Uber categories of dressing and bathing, meal preparation and eating, ambulating, transferring, toileting, personal hygiene, navigating stairs, and safety and emergency responses. ultimately, it's important to keep in mind that so long as two or more of these are deemed by a physician as being something you need assistance with due to physical or cognitive or both types of impairment, your long-term care insurance must pay. If you're having any difficulty with that, the Texas Department of Insurance will gladly assist you. Now, keep in mind that you have to continue to pay these premiums until care is needed and continue to pay those premiums. And if you let it lapse, you might not be able to jump right back in where you left off. So your mileage may vary widely depending on which companies, and there aren't that many left, that offer long-term care insurance have in terms of provisions, if any, for gaps in premium payment. Short-term care insurance is a little bit of a different animal. It is definitely simpler underwriting. It's definitely a lower cost, roughly $1,000 a year for, on average, $150 per day benefit. And it will cover generally up to 260 days for in-home care or facility care. But when it's done, it's done. So keep that in mind as well. And many of the same underwriters of long-term care insurance policies are also going to offer short-term care insurance plans. Make sure you look through them with a fine-tooth comb. And if you need an attorney to help you with that, please make use of either your own personal attorney or the services of various clinics and programs such as the Texas Legal Services Center, Lone Star Legal Aid, and more. We're going to skip past these for the sake of time, and of course, give you a chance to look at the slide deck on your own later on. I want to talk for a moment about reverse mortgages. I am not here to sell you on a reverse mortgage. I am not here to tell you to avoid a reverse mortgage. What I am here to tell you is that if you have done your due diligence and you feel comfortable going ahead and essentially creating, and all this is a different form of home equity account, where ultimately you can go ahead and take monthly payments for whatever purpose, whether they're supplementing your ordinary expenses or whether they are there to help pay unexpected expenses. You can utilize the equity on your home for monthly income, regardless of the reason. Obviously, the bank gets paid back first after you die and when that property is sold. It is very often like many financial instruments in American life, it is simultaneously subject to amazing amounts of regulation, and there are wild stories, anecdotal, about its abuse by people providing them. All I can tell you is, from personal experience, my mother of blessed memory did her due diligence, got a reverse mortgage on the home that was fully paid for, so that, and it was her decision. Her children, including me, obviously, were perfectly happy to go ahead and to supplement her monthly income. She said, I have an asset I can make use of to supplement my monthly income. No one is going to move into the house after I die. It's just me. It will be sold, and obviously any balance that I owe will be paid before the estate receives the proceedings from the sale. It worked. She did her due diligence. It improved her quality of life. Your mileage may vary wildly. Do as much research as possible. We're going to leave annuities for you to look at on your own. If you have them, you are probably better versed at them than I am. But I will go ahead and turn to the resources page as we wind up. to go ahead and let you know what kind of resources we recommend you look at when you are considering the best possible plans for you in terms of paying for aging. We're talking about traditional Medicare versus Medicare Advantage. We're talking about what it means to go ahead and to tap into the equity of a home. We're talking about all the financial instruments we've mentioned in terms of paying premiums for long-term or short-term care insurance, hybrid life insurance plans that also offer a health benefit, annuities that you may own. If you need advice on any of these, ultimately, there are resources out there. They start ultimately, though, with making sure you know what your costs are going to be. And that's where what's on this page is going to help you, not only in terms of the costs of acute care stays, but also post-acute care stays. Who are your scouts if you are considering long-term care facilities and how to pay for those? That's where the Area Agency on Aging and long-term care ombudsman programs are going to come into play. If you are financially limited, what can you do to maximize your benefits? Whether you are a civilian, whether you are a veteran, and that's why we have links here not only to Medicare Advantage plans, but also to medication assistance programs, Texas Medicaid and CHIP, geriatrics and extended care programs for veterans. Moving forward from this, if I can find my cursor, there we go, some references. We encourage you to read through these, which in turn will likely lead you to even more references about the increasing costs of aging in place, of long-term care, in between acute care stays and post-acute care stays, making sure you stay up to date on what the various Medicare premiums are and the out-of-pocket costs that are associated with those services. And Medicare.gov, CMS.gov are, of course, going to be your primary points of contact for general information, though interpretation of that information is certainly something the Area Agency on Aging and Aging and Disability Resource Center in your county can assist with. I mentioned Lisa Falkenberg and a couple of her articles in particular. Yeah, they're a few years old, but they're still very, very relevant to this whole process of making sure you understand when you choose, say, a Medicare Advantage plan, what are the limits in that plan, as well as the perceived benefits and actual benefits. Genworth is going to go ahead and be one of many different sites you can turn to go ahead and help you understand whether it's worth investing in long-term or short-term care insurance. I mentioned HealthView services at the very beginning when it comes to the cost of retirement for individuals and families. And when it comes to understanding what long-term care facilities in Texas are supposed to provide, Texas Health and Human Services is the place to start. With that, a reminder that we, Peggy and I, are always here to offer individual consultation, resource sharing, to make referrals as best we know how, based on whatever questions you have related to any aspect of aging with grace, not just today's paying with aging element, but the other elements that we've described, healthcare rights and responsibilities, legal aspects of aging. When we talk about the idea of choosing a long-term care facility, if that is the direction that you are going in, or if you're looking at independent living facilities, in other words, not aging in place at home, but not necessarily in need of skilled services on a daily basis to assist you with your activities of daily living. Or if such assistance is required, it's to supplement what you truly could do on your own if pushed. all of this is a maze, and we want to help navigate you through that maze as best as possible. And what we know, we'll share. And when we don't know, we'll research and we'll refer. Let me go ahead and stop sharing. Go ahead and check our chat to see if we have anything in here. There is a question from earlier. Are the laws in California different when it comes to home care? Great question, which I believe should be directed to the county in California that you may be considering, that you live in, that a loved one lives in. Their area agency on aging, their Aging and Disability Resource Center is going to tell you what the differences may be in the state of California versus Texas or any other state in the United States. I can't speak to outside of Texas, I'm afraid to say. Well, thank you for those of you who have stuck it out through today, stuck it out through the entire series. As I mentioned to you at the beginning of this session and at the beginning of every session, we're going to get this out to all of you. If you registered for whatever sessions you registered for, you're going to get the link to the recording, and you're going to get the slide deck. If for some reason you didn't register for a particular session, it's going to be up on our website with all the other sessions in, I would say, the next few days. And it will certainly be available to you through the resource tab of our website, hhci.org. I truly appreciate the thank yous coming in. We're here to help however we're able. God bless everyone and have a wonderful week. You all take care.